Hello everyone, my name is Joshua Finn, Administrator for Foot Healthcare Associates, and welcome to PCMH Training, the Basics of PCMH Neighborhood. Before we start, we go over a few notes about the presentation. First off, the training is mandatory. All policies discussed for PCMHn related to our practice are located on the server under the Common Drive. This presentation itself can also be found via the PCMHn training material listed above. This training covers only the basics of PCMHn as related to foot healthcare associates. Deep dive training on individual policies will be provided with each update to the policy and as needed. Policies are reviewed at least annually and updated with any workflow or requirement changes. This training is required annually as a refresher for all staff. As we go through the following information in this presentation, please write down any questions you can think of so that they can be discussed. Blue Cross Blue Shield of Michigan has partnered with our physician group, the Physician Alliance, also known as TPA, to create guidelines and regulations necessary for providers to be certified as PCMH capable. By meeting these measures set forth, providers can not only help enhance patient care, but also be incentivized for maintaining and growing with ever-changing PCMH requirements. What is the PCMH neighborhood? So now that you know a little bit about why we are doing this training, you may ask yourself, what exactly is the PCMH neighborhood? In order to understand what a PCMH neighborhood is, we have to understand what exactly the patient-centered medical home is and the concepts of how it works and the components of the sections that make up PCMH protocol. Before we dive in though, a little basic background about PCMH. The PCMH model of care began with the American Academy of Pediatrics in the late 1960s. It provides comprehensive primary care for children, youth, adults, and even seniors. It facilitates partnerships between individual patients, their primary care physician, and specialist. It acts as the central hub of patient information and care coordination. It expands the care team to include healthcare professionals such as nurses, pharmacists, care managers, and others. The primary focus of PCMH is on population management. Just to give you a quick visualization of the PCMH structure and its patient-centric fundamentals, here's a quick diagram. All the center of the PCMH is the patient and their primary care provider. All services outside the patient and the PCP are referred to as the neighborhood. This is Foot Healthcare Associates, one of the specialists. This is us. FHA has been PCMHn certified since 2013. FHA was actually the first podiatry practice in Michigan to receive the specialty designation from Blue Cross Blue Shield. Seeing what PCMH looks like, we can move forward and discuss PCM's core guidelines. PCMH consists of 13 basic core principles and guidelines, and they are as follows. Patient-provider partnership agreement, patient registry, performance reporting, individual care management, extended access, test tracking, e-prescribing, Preventive Services, Linkage community resources, self-management support, patient web portal, coordination of care, and specialist referral. We will spend a minute or two on each of these topics so that you better understand what exactly each core means and what component it consists of. The first of the core principle is Section 1, the patient-provider partnership. Its goal is to provide patients with information and education in order to understand PCMH and the team approach to their healthcare needs. This section entails communicating with patients via discussion and paperwork. Patient paperwork includes PCMH information, material, and documents. It is given to all new patients and old new patients. To oversimplify what the info states, basically, we work with your primary doctor and subspecialist to coordinate your care for the best outcome. So, what does PPA look like? It is a 2-page document given to the patients and is printed out with the new patient paperwork on the digital check-in paperwork and portal. Patients can even find it by searching the web or pulling it off our website. Okay, that's what it looks like. So what exactly is on it? First off, it defines PCMHn, patient responsibilities, provider responsibilities, what to do after hours, or going to urgent care basically, community service, and patient portal access. Next, we move on to the Patient Registry, where we focus on our chronic care community, which of course is our diabetic patients. The goal is to provide diabetic patient info to providers in order to fill gaps in care and ensure CDFEs, or the comprehensive diabetic foot exams, are performed at least annually. So, what is it? Boiling it down to the basics, Patient Registry is an organized system that uses observational study methods to collect uniform data, clinical and other, to evaluate specified outcomes for a population defined by a particular disease, condition, or exposure that serves predetermined scientific, clinical, or policy purposes. Of course, we focus on diabetes. So, how is the registry made and where does it come from? Our diabetic patient registry is housed within Athena, actually. The registry list is generated by using the practice management reporting system. The report titled Diabetic Patient Registry is actually found on Athena's report library. The registry is generated annually or as needed when audited to provide a list of all active diabetic patients seen in the office. What is it used for? The registry is a database which helps determine which patients with diabetes is under our care. This list is self-populating based on the diagnosis used by the doctor during a patient visit. So we just discussed the patient registry requirements. Next, we will look at Section 3, Performance Reporting. The goal of reporting is to ensure continued provider performance progress and reporting on patient population is relevant to our practice. This also goes over and covers our chronic care model, which we'll go over later. But example of this can be seen when we complete the CDFE, the comprehensive diabetic foot exam on patients, and the intake quality section during the flow process for the patient's visit. This is added to the numerator for the CDFE measure under the MIPS quality reporting. A score is determined simply by taking this numerator and dividing it by a denominator, which is the total number of patients that qualified for the CDFE during that reporting period. Once we fill in the date, the measure requirement will disappear until the time the CDFE is due again. Next, we move on to the fourth requirement of PCMH, which is individual care management. This is one of the larger and more complex components of PCMH. The goal of ICM is a subset of many requirements aimed at improving continuity and quality in the management of patients living with chronic illness, also supporting physicians and other healthcare providers to use the best medical practice or evidence-based guidelines. It is a model focused on continuous improvement of diseases. Some of the components in this section include the patient PCP satisfaction surveys, care management services, medication reconciliation, appointment tracking and reminders, staff training requirements, and of course, CDFE outreach campaigns. And as I said earlier, one of the most important components of ICM is understanding the chronic care model. The chronic care model will also be discussed in a separate training annually, since it covers material that can't really be discussed in just a couple of minutes. However, we will touch on the basics here. A CCM is defined as the components, an organizational approach to caring for people with chronic disease. The system is population-based and creates practical, supportive, evidence-based interactions between an informed, activated patient and a prepared, proactive practice team. The components of the CCM consist of delivery system design, which is proactive versus reactive, using planned interaction based on evidence-based care with designated roles amongst team members. Decision support, promoting clinical care that is consistent with evidence-based guidelines. In other words, those that are based and proven by scientific evidence. Clinical info systems, reminders, proactive care, individual care planning, care coordination, monitor performance. Self-management support, which emphasizes patients' central role in managing their health, providing resources to help ongoing self-management support. And lastly, community, which encourages patients to participate in effective community programs like the American Diabetic Association and to promote self-helping strategies. Moving from individual care management, we move on to Section 5, extended access. Obviously, the goal of this requirement is to ensure access to clinical care and a clinical decision maker outside normal clinic business hours. Patient needs are not only during normal weekly business hours, and believe it or not, can have needs that occur when the clinic is closed. The guidelines within this requirement include updating the EMRs same day or next day or same night, basically. Patients informed regarding urgent care or on-call doctor availability. Access to foreign language or sign language translators. Patient access to non-emergency department after hours. And lastly, urgent care provides updates and feedback loops on the patients of ours being seen. So we understand extended access, so let's move on to Section 6, test result tracking. The goal of this requirement is just as it sounds, to ensure that all ordered tests are completed, results are received and communicated to our patients in a timely manner with recommended follow-up as indicated. To meet test tracking standards, orders or the tests are built into Athena's workflow. Alarms can be set on an order to ensure that needed test results are received in a timely manner. Follow-up on test results are indicated within the clinical inbox for staff follow-up. This is all automated. All audit history is recorded within Athena to track steps in tracking test orders and results. Simple, right? Test tracking is a simple protocol to follow, considering that it's mostly embedded with our EMR's workflow. The next section, labeled number 7 of our PCMH packet, is probably the simplest of all the guidelines, however, that we discussed today so far. It is simply a section within a digital or paper binder that houses practice files for documentation purposes and future updates. This section currently has no need for discussion. So we move on now. So one of the newer sections added to PCMHn requirements, it is Section 8, EPCS, which stands for Electronic Prescribing of Controlled Substances. The goal of this requirement is to ensure that our providers follow all regulations in order to safely prescribe controlled substances and to ensure that patients are not overprescribed controlled substances. The goal, of course, of this requirement, as discussed, can go either way for all providers, and we need to make sure that all providers are e-prescribing over 75% of all pharmaceutical prescriptions, non-controlled and controlled. And also providers are reviewing controlled substance agreements with the patients when they do prescribe a narcotic. Patients need to sign off on these controlled substance agreements. That's basically it for Section 8, pretty simple. So we've dealt with the ERX at one point or another. So let's move on to something else we all have a part in, which brings us to Section 9, Preventive Services. As before, we start with the goal of this section. The goal is to ensure that our patients receive services and education on their health conditions. To meet the standards required in this section, we provide education materials to patients on prevention with a systematic approach, outreach regarding CDFE, screenings and missed appointments, tobacco cessation tools, and smoking cessation advice, written standing order protocols such as the diabetic shoe dispensing, which are done without exam. And lastly, continued staff education on conditions and preventative service updates. So we move on from Section 9 to Section 10, Linkage to Community Services. The goal of this program section is to provide info to our patients for local community agencies when physicians find it necessary and helpful for his patients' well-being, and when patients feel they need to contact an agency for help. To achieve this goal, we need to maintain a community resource database, educate all patients about community resources and referrals, track high-risk referrals by documenting within our EMR, provide follow-up on high-risk patients, use the community binder or online NowPal, which we'll go over later, or provide staff with ongoing training and education, of course. And as I mentioned, NowPal is a website that can provide community resources to staff members for patients by entering in those patient needs within a location, and will provide some options within that website or app. Further training will be provided to staff members on how to use this NowPal in the future. So in the same vein of helping out individual patients, we move on to a section focused on helping a specific set of patients in Section 11, Self-Management Support. Self-management support's goal is to enable and encourage patients to become good managers of their health by helping to set their own goals and decision-making for smoking cessation for those with diabetes. The following guidelines apply for Section 11. We offer self-management services for smokers with diabetes with A1C greater than 8. It's offered to all the patients within the condition parameters. Patients set their own goals. We encourage and follow up on those goals. Follow up to provide action plans and update patient goals as we move along. Patients are added to a separate spreadsheet by the staff when they qualify and elect to become and participate in this program. This spreadsheet is updated at least quarterly by our project lead reach out. The goal that we set for the patients actually must be realistic, achievable, specific, measurable, timely, and repeatable. The patient must have a confidence level of at least 7 out of 10, or else we'll have to reestablish and find a more comfortable goal for that patient. And once we reach that goal, we'll put that goal down and we can move on from there and hopefully move the goal up as we move along in time. So moving on to Section 12, the Patient Web Portal. The goal of this portal is to provide patients with electronic access to their medical records as well as electronic access to their providers. Now PCMH actually has requirements set forth in order to meet their standards. These requirements are: provide patients with access to request scheduled appointments online, provide telehealth options to patients, send reminders and health education through the portal, send test results for patient review through this portal, and also ability for the patients to review health records and summaries. All of these components are important for meeting PCMH requirements for the web portal. So, discussing patient access to our practice and providers, through the portal, let's discuss now what we do to help the patient access other providers. In section 13, we discuss the coordination of care. Our goal in this section is to work in a partnership with the referring primary care physician and other specialists to coordinate the patient's healthcare needs as they transition through the healthcare system. To meet the PCMH requirements for section 13, we must have a process in place for medical record exchange to and from other covered entities for all patients. Referrals to outside sources flagged for time-sensitive health issues for all patients. Having a process for transitioning patient care for those leaving the practice for all patients. And work with our primary care physicians and care managers to coordinate needed services for mutual patients. This increased quality and efficiency will ultimately reduce costs and can help stabilize a shaky healthcare economy and patient population. That is our main objective for coordinating patient care. As discussed earlier, we are not the only ones caring for our patients. Not only do we care for the patient, but of course we communicate back to the patient's primary doctor. We also occasionally send our patients to other specialists, also known as subspecialists. In section 14, we go over the specialist referral. The goal of this section is to provide bi-directional communication between the practice, the PCP, and/or the subspecialist. Section 14 actually is the last section for the PCMH requirements, and here are some of the finalized requirements for section 14. We have to define protocols of the referral process with timeframes and scheduling procedures. We have to provide the patient with informational material on specialist referrals. We have to have a process to confirm incoming referrals from PCPs and follow back to the PCP. Include the subspecialist visit satisfaction in the patient surveys. We also communicate this back to the primary care physicians and our patient satisfaction results that we share with them. We follow up with the PCP. The doctor follows up with the PCP for self-referred patients that they send to subspecialists. The doctors can either send their letters, they can contact the primary care physician directly via phone call, text, or whatever the doctor prefers, or however the primary care physician prefers to be reached. It's also a great way for our doctors to stay in communication with the primary care physicians, very important to our practice. So to finish up, and though before we go, let's note that PCMH is a team-based, patient and family-centered care model focused on comprehensive, coordinated care that improves the quality of care for all patients while reducing the overall healthcare spending. PCMH offers opportunities for all clinical staff to improve care coordination and patient care outcomes. Continuous quality improvement research is important to identifying stumbling blocks which improve team dynamics and processes. Simply put, that just means we all play a part in making sure that we are meeting patient expectations, discovering inefficiencies, and producing better outcomes for all of our patients. So ultimately, the goal of PCMH is to achieve improved patient experiences, improved population health, and superior cost, otherwise known as the triple aim. So that's the basics of the neighborhood. Please direct any of your questions to me regarding PCMH. Here's my contact information if for any reason you do not have it already. We will be covering some of the sections in more depth throughout the year, so a good understanding of the basics is very important to developing the foundation needed to move forward and build upon. Again, this presentation can be found on our server as well as our staff training site. Please feel free to browse or replay anytime you feel like refreshing or just simply review information. So this concludes our presentation on the basics of PCMHn. Until next time, this is Mr. Finn signing off. Take care, stay safe, and good luck.